to me why something that inhibits reuptake is an agonist. Can you explain to me why it is that an opiate, you can give somebody an opiate and an opiate antagonist at the same time and relieve pain but not cause constipation? So this is on page, blah, 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 blah. This is under opiates. Page, is it 3? 7? Okay, it's not very close at all. All right, so why would that be? And it's kind of like the myasthenia gravis thing. So with myasthenia gravis, you had muscles, right? And then you had all the autonomic, this is supposed to be your stomach. This is bad. Right? Pupil of the eye. In the muscles, you had nicotinic receptors. In the autonomic nervous system, you had muscarinic receptors. So if you wanted to increase acetylcholine for the myasthenia gravis patients, you could give a stigmine drug, right? And that would increase acetylcholine everywhere. So it would increase acetylcholine for the skeletal muscles, which was very useful for myasthenia gravis. But it would also increase acetylcholine here and stimulate all your autonomic nerve target organs. So that was a situation where you could give an agonist, which was a stigmine, and an antagonist simultaneously, because atropine only blocks muscarinic, right? So here, what happens is the atropine blocks the effect of acetylcholine on the autonomic organs, but it has no effect on the neuromuscular junction. Because otherwise it might not, I don't think it makes sense otherwise if you don't know that, because why would you give an agonist and an antagonist at the same time? That's pointless, you're just canceling them out. But that's because of this. Similarly with the opiates, right? There's like your brain, right? And then there's your bowels, right? So if an opiate, like morphine, if it crosses the blood-brain barrier, it'll bind mu receptors there and reduce pain. Okay, so like that's morphine. And it'll bind mu receptors in your intestines and make you constipated. And the constipation patients get from opiates is pretty epic. I mean, it's not just mild, it's like they really have trouble pooping. All right, so these new drugs that have recently been released in the last couple of years, what they are is they are a mu antagonist, okay, but they don't cross the blood-brain barrier, right? Does that make sense? So now you can block those mu receptors in the bowels so you don't get the constipation, but you will not block the mu receptors in the brain, so now the patient can get relief of their pain from morphine. You're looking at me very skeptically. Does that make sense? Okay, so that's I mean, this just recently came out and people are very excited about it. Nobody wants to be constipated. That's no fun. Okay. Okay, so I wanted to mention that. And all right. Did you guys find this kind of thing helpful? The little critical thinking questions? To sort of read through. Okay. I worry that I'm giving you guys too much stuff to look at and then you're overwhelmed when you're trying to study. But what happens is every semester I ask students for suggestions and they keep suggesting more stuff. And pretty soon there's like this enormous pile of things for you to do and I don't want to do that. You know, you can pretty much be sure that my tests are only gonna include stuff that's in the handout and in the quizzes and the worksheets. That'll be it. All the other stuff is sort of extra stuff. Okay. All right, so today we're going to talk about drugs that are inhibitory drugs specifically, okay? And we already talked about glycine being inhibitory and GABA being inhibitory. So the way that GABA is inhibitory is that it binds, it has a receptor on the chloride channel. So if this is the chloride channel, here's chloride going through. Chloride is a negative ion, so it causes hyperpolarization, which means it's inhibitory. I had one student ask me, how do you remember which ones are negative and which ones are positive? I think all the electrolytes we talk about in this class are positive except for chloride. So if you can remember Cl negative, all the rest of them are positive. Okay, So on this channel, you have a receptor for the neurotransmitter GABA. You also have a receptor for the class of drugs called benzodiazepines. You also have a receptor for the class of drugs called barbiturates. And the new non-benzodiazepine GABA agonists, nobody's thought of a better name for that, so that's what it's called. From what I've read, that also has its own receptor. And that's really interesting because if there's a receptor there that opens the channel, it means that either there's some chemical in our bodies that binds that receptor. We don't just have a receptor for no reason. Or we used to have a chemical in our bodies that bound that receptor that just doesn't get used because of evolution, and the receptor's just left over. So it's very weird. But the thing is it doesn't matter which one of these receptors is activated, either by GABA or benzos or barbiturates or the non-benzodiazepine GABA agonists. It doesn't matter. All of them increase chloride movement. They're all hyperpolarizing. So you'll see a lot of, in different texts, some of the textbooks, they refer to benzos and barbs and the non-benzodiazepine GABA agonists. They refer to those as GABA agonists because they have clinical actions like GABA because they hyperpolarize and inhibit. But they aren't really GABA agonists. They're not direct acting that way. They are direct acting in that they bind their own receptor. And you might say, well, who cares? It does the same thing. It's because you don't want to mix benzos with barbiturates. They're binding different receptors, so you're going to get more effect when you do that. Okay, so if you only had one receptor that they were all binding, then combining the two would just be like doubling the dose of one. But since they have their own receptors, if you give them together, you're going to have a synergistic effect. Okay. I think on the first, on the page, this page, do I have it? I thought I took it out. Oh, I didn't take it out. This, just cross this out, who cares? This says benzodiazepines cause ion channels to open more frequently. Barbiturates cause them to hold open longer. The point is they both increase the chloride movement in different ways. They have their own receptors, so you don't want to combine them because you'll get higher effect. Okay, does that make sense? Yes, sorry.
Does glycine have a receptor spot?
I don't know offhand. I would bet it has one too, depending on where it is, but I don't know. I'm sorry.
Doesn't that increase chloride ions?
I would think that it would.
Because it's inhibitory?
Because it's inhibitory. I will look it up and tell you next week. All right, so these are all inhibitory drugs, so they all work for things where there's too much stimulation. So you can't sleep. You know, these are good for that. Oh, you're really nervous and anxious, no, good for that. If you're having a seizure, that's too much firing in your brain. If you're awake and somebody wants to do surgery on you, these are good drugs to use. So all of those things fall under the purview of these drugs that act like GABA. There's a few exceptions, and we'll talk about some of those. Okay, now what I've done is there's a lot of chapters. There's 4 chapters in the next, 4 pages. What I've tried to do is go through the chapters, pull out the stuff I want you to know, and just keep moving. Okay, so I don't, if you ran out of study time for the first test, don't go spending lots of time reading the textbook. Read this, make sure you got this stuff down, then go and look for other information, to increase your understanding. Yeah.
Just but that's the textbook reading. Do you want us to read the whole chapters or just the portions that you highlighted in this packet?
No, I want you to read the handout. If there's something in the handout you don't understand, then do the reading.
Okay.
Don't. I've done the work for you. Almost everybody who takes my class is either in the nursing program or has 2 full-time jobs or 15 children or 27 grandparents they're taking care of or whatever. Everybody has other things they're trying to do. I'm not trying to make the information easier. I'm just trying to help save time so you don't have to spend time getting that information out of the chapters. Okay, so I am trying to help you despite what you might think. All right, so that being said, the chapters, it doesn't matter which book you're using, go through all different kinds of diseases, all kinds of pathophysiology. I don't want to spend a lot of time doing that right now. So when I talk about sedatives and hypnotics, sedative means sedation, means you're calming someone down. That sometimes puts you to sleep, but you're calming someone down. Hypnotic specifically means you're putting them to sleep. I'm not going to go through all the different kinds of sleep disorders and which drug is best for which. You can learn that later. If you can learn that the drugs are for sleeping problems, I would be so happy. All right. So you probably know sleep. There's different stages of it. Then you get REM sleep. You need your REM sleep in order to feel refreshed. There's all sorts of apps that will tell you what stages you're in. It's very cool. There's not only insomnia, but there's night. You know, when you walk around at night and you're asleep. Sleepwalking. Sorry. And there's night terrors and narcolepsy, where people fall asleep. We're going to just talk about regular old, boring, normal, Western insomnia caused by having a job 5 days a week and staying up late or sleeping in on the weekends. So unless you have children or cats, you probably sleep in on the weekends more than you would otherwise. And the problem is that when you don't go to sleep at the same time and wake up at the same time every day, your circadian rhythm gets screwed up. And if your sleep cycles are screwed up, any brain problem you have is going to be worse. That includes Parkinson's and Alzheimer's and depression and mania, all those things. Sleep, your circadian rhythm is incredibly important. So we're going to talk just about sort of plain old regular insomnia. Now, insomnia of that type, there's only one way to fix that, and that is to get people to go to sleep at the same time and to wake up at the same time every day. That's called sleep hygiene. So there's no reason for a patient with that problem to have to be on a sleeping pill for more than a month or two. That should be plenty of time for them to get their cycle in order. Now, if they're a shift worker, like a nurse, then that's very difficult to manage. That's why a lot of nurses seem cranky, because it's not because they're bad people, it's because their sleep is all screwed up. For a lot of those people, you can use melatonin. So, did you guys talk about melatonin in A&P? Is that something? So melatonin, basically that's like a little alarm clock in your brain. So melatonin, it's released by the pineal gland, and what that does is it's like a little ping at the same time every day. And it just tells your brain, okay, this is a new 24-hour cycle. People who are completely blind in the dark, they can't even see movement, their circadian rhythms are incredibly screwed up, and they really benefit from melatonin or the melatonin agonist, which is like ramipril. You'll see it looks sort of the same as melatonin. The thing about melatonin is you have to take it at the same time every day because you're trying to set your circadian rhythm. But melatonin, because all it's doing is setting your rhythm, it does not inhibit your medulla oblongata. So if you have a patient who's taking other inhibitors of the medulla oblongata, melatonin is safe to add to that. Okay, so that's kind of a good thing to know. So it's all about circadian rhythm and having that fixed. Yes?
So does melatonin help you sleep, or does it just help you, like, your brain know when to wake up and when to?
So melatonin really will help you fall asleep once you get on that sleep, once you are committed to the sleep schedule. You take it at the same time every day, and then it helps you get to sleep. It's very short acting, so it will not help keep you asleep. There's a lot of disorders where you wake up in the morning. It can't help that, but it will help you. It'll help your brain know that it's sleep time if you get that stuff.
Can you take it more than once a night?
That would defeat the purpose.
My sister takes it, which is why I was asking.
Well, again, if it works for her, then.
Well, she has arthritis, so she takes a bunch of other medications, and this is what they give her to help her sleep, which is why I find it.
Yeah, but the point is that you want to have the peak once a day so that you have the circadian rhythm fixed. Okay, all right, so different drug classes that work. So you're going to see that for the next 4 chapters worth of material that's in this handout, it's going to be benzodiazepines and barbiturates. So benzodiazepines and barbiturates work for all those 4 things, which is insomnia, anxiety, seizures, and anesthesia, right? Benzodiazepines are a newer class of drugs than barbiturates. I think the first one was Valium, which was in the 1960s, and there was a big craze, everyone was taking Valium. There's lots of different benzodiazepines. Almost all of them end with Zepam, or at least am. So I've only asked you to learn 2 benzodiazepines, and I've picked 2 because I want you to totally notice that they end with the same thing, a PAM. So if you can recognize a PAM as benzodiazepine, you are golden. I've also asked you to learn these 2 because these are the 2 that you generally would use in an emergency. So, because they're very short acting. So, etc. So, those are the 2 I want you to know because, and that's Valium and Ativan, which is diazepam and lorazepam. okay? But if you're helping somebody fall asleep, it probably is not going to work. Those are probably not going to work as well as something a little more long-acting, or depending on what the problem is with the sleep. If it's, do they stay asleep? Do they fall asleep? Do they wake up early? All the benzodiazepines and the barbiturates and most other seizure drugs are category D or X. You absolutely, if you have somebody walk into your office who has a working uterus and a working pair of ovaries and they're sexually active with males, then you have to be sure that if you prescribe benzodiazepines that you tell them that they should be using birth control, because if they get pregnant, there's a 10 or 20% chance of a birth defect. Now, benzodiazepines alone are fairly safe, but in combination with any of those other respiratory inhibitors, they're very dangerous. So a lot of people self-medicate with alcohol, a glass of wine before bed. They're just self-medicating with that. Make sure that if they're doing that you explain you don't want to combine these two, or you want to be very careful about that kind of thing. Does that make sense? All right. Look, since I have it here, I'm going to mention it now. Something like diazepam or lorazepam is very good for a condition called alcohol withdrawal. If a person is under alcohol withdrawal, how much alcohol is in their bloodstream? If you're undergoing withdrawal from alcohol, how much alcohol is in your bloodstream? None. I hear it, but none. Right, none. Okay? If you have alcohol toxicity, how much alcohol is in your bloodstream? Too much. Right? Because I see students get all mixed up with those two. Right? So for alcohol withdrawal syndrome, called the delirium tremens, DTs, you can use a benzodiazepine to stop those seizures and to treat the alcohol withdrawal, because alcohol withdrawals can kill you. Heroin withdrawal generally won't kill you, even though you will wish you were dead because you feel awful, but alcohol withdrawal can kill you. So, but I've seen students write, well, the patient has alcohol toxicity, so I'll give them diazepam. No, that will kill them, so don't do that. Make sure you understand withdrawal means none of the drugs in the system. Toxicity means there's too much in the drugs. And you'll see this happen. So you'll have a patient who comes in for some reason they weren't planned, like they got hit by a bus or they had a heart attack, something. They weren't planning on being in the hospital. They're brought to the hospital, and about a day or two into their hospitalization, they start acting weird, then they start seeing things, then they start shaking, and they have a seizure. That's the DTs. And generally what's happening there is that patient was drinking, a case of vodka every day or whatever. And when they came into the hospital, it was a sudden stop of alcohol, and then they go into withdrawal. You can't treat a patient who has the DTs with alcohol. Number one, because sometimes they're unconscious. You don't want to just pour booze. And the second thing is, if you have alcohol in the hospital, people who work at the hospital will drink it, generally speaking. The rate of drug abuse among healthcare workers is actually quite high, especially ones that have access to the drugs. Nowadays, there's usually all sorts of locks and passwords and things, and you have to document everything, and that's because people are just taking the drugs, and there was even a TV show about a woman who was a drug addict, right? Very common. I'll just tell you a story that when I was in my training, my now ex-husband, it was a ENT resident at University of Maryland, and one day one of the anesthesia residents went missing. Where did he go? We don't know. And they finally found him. He had locked himself into an empty patient room. When they opened the door, he was in there stark naked, hooked up to an IV of some anesthetic drug. And you'd think, well, of course, he must have been fired. No, because it happened all the time, evidently. So they just sent him off to rehab or whatever, and then he came back and everything was fine. It's that common, okay? So you can't have just, Johnny Walker in the nursing room. It will not last. You can't do that. And also, it's a little bit harder to titrate that dose, whereas the diazepam, you can titrate it. So the idea is they have their alcohol withdrawal, give them diazepam to stop the symptoms, and then every day you give them a little bit less, you taper the dose, and then when they leave, they're safe. If they never drink again, they'll be fine. So, and the other, and like I said, you're bound to see this happen. A lot of patients who drink a lot don't tell you they drink a lot, and then something like this happens, and you find out. Okay, so that is benzodiazepines. Barbiturates are an older class of drug. They are evidently used a lot in geriatric medicine. Still, again, old people and babies are like different species, so I don't want to get into that. But phenobarbital is the older drug, and they still can be used. The problem with barbiturates as compared to benzodiazepines is that barbiturates have a worse effect in terms of reducing your REM sleep. So patients who use barbiturates to fall asleep often don't feel very good when they wake up in the morning. They don't feel refreshed. The one barbiturate I'm going to ask you to know is peanut butter ball or phenobarbital. I had a patient who I was taking the drug history, and he said, "I take peanut butter ball." I said, "What is that?" And he said, "I take it for my smiling mighty Jesus." I'm like, "What?" And then I found out, I went back in his record. He was taking phenobarbital for, he had had spinal meningitis and it left him with a seizure disorder. So when I see phenobarbital, I think of peanut butter ball. You're welcome to write peanut butter ball on your quizzes for me. Don't do it for nursing classes with me. All right, so that's the only one I'm going to have you learn. Phenobarbital is actually tends to be used more for seizure disorders, epilepsy. It's dirt cheap. It works great. And the hangover effect of the REM sleep problem supposedly wears off after about 2 weeks. So a lot of those effects go away because your brain sort of figures out what the problem is. Okay. Now, another thing about barbiturates, there's two other things to know about barbiturates. One is they are really bad in terms of causing something called automatism, which is a problem old people have anyway, and evidently it's really bad with old people, where the patient takes their medication in the morning and then can't remember if they took it, and then they take another one. And they're like, "Did I take it? I don't know, I'll take another one." And then they have to be in the emergency room. So a very easy fix is you get a pill dispenser. So have you guys seen these pill dispensers in, you get it for $1 at the dollar store, I know for sure. And they're just a little box, and they say Monday, Tuesday, Wednesday, Thursday, Friday. What you do is you load them up at the beginning of the week with their doses for every day, and then if it's Monday, they take their medication, and then if they can't remember if they took it, they go and look, and if it's empty, they know they took their medication. So that's a $1 preventative measure to possibly save someone's life. The other thing about phenobarbital and barbiturates in general is they do induce their own enzymes, quite a lot, evidently more than benzos, although benzos do it too. So just something to, so that's why people tend to use the newer drugs than the barbiturates. Even though barbiturates can be used, it's just that there's more drug interactions and there's the automatism. It's just, people don't want to use it. All right, then the newer, all right, so again, I'm just going to point out, memorizing the representative drug of each class. For benzodiazepines, it's Zapam, okay? A lot of drugs end with other things. I'm just asking you the Zapam ones, okay? Zapam. Barbiturates, Barbitol. That's a pretty easy one to remember, right? So the representative drug is peanut butter ball. Okay, then the newer non-benzodiazepine GABA agonist drugs, which, again, that's the name of the class, I don't know. I've asked you to learn 2 of those, and it's not the generic names are Zolpidem and Zaloplan. And the way I remember that is that when you are sleeping, right, then you do this, right? So the Z drugs, Zaloplan and Zolpidem, are the help you sleep medications. Supposedly, the newer drugs don't cause as much in the way of birth effects, and supposedly the dependence on those drugs is not as bad as they are for benzos. That's one. I already talked about melatonin. Now, I talked about alcohol withdrawal in the situation where you can have that. If you have somebody taking benzodiazepines and they're taking it for years, right? And so they need more and more benzodiazepine as they're going along. And if they suddenly stop it, what happens to them? You have withdrawal and you can have a seizure, right? If you give a regular patient something like flumazenil, which is a benzodiazepine direct-acting antagonist, or naloxone, you could also possibly see a seizure. Why would that be? Okay. So, if So if you can imagine that if you're taking a drug that's inhibitory, like a GABA drug, like a benzodiazepine, all right, that's inhibiting your brain. So it's inhibiting your reticular activating center, so it's helping you fall asleep. It's inhibiting your whole brain. And you're needing higher and higher doses of it. And remember, anything that's an outside drug, your body is going to fight a little bit. So if the drug you're taking is inhibitory, then all the nerves that are excitatory, right, because every nerve center in your brain has inhibitory and excitatory, are going to ramp up their activity. So when you stop the inhibition suddenly by either stop taking the drug or out of nowhere giving the anti-benzodiazepine, what happens is you're blocking the inhibition, you get excitation, and you have the potential for a seizure. Does that make sense? Right? Same thing with alcohol, obviously. It's inhibitory. If you suddenly take away that inhibition, either by taking away that drug or neurotransmitter or booze, or you inhibit it by blocking receptors, and the excitatory side wins and you can have a seizure. Yes?
What did you say inhibits? What drugs?
Benzodiazepines, barbiturates, alcohol,
Or what would
opiates.
like inhibit the inhibitor? Is what
So benzodiazepines, flumazenil is the most common direct-acting antagonist. For opiates, it's naloxone or Narcan.
okay.
There's nothing really for alcohol or barbiturates. You sort of have to just, if they have an overdose of that, you just have to kind of wait it out.
So if you give those, that would cause the excitatory, which would cause the seizures?
Right, so if you inhibit this,
Uh-huh.
then you could have a seizure.
Okay.
So for instance, if you have somebody who's overdosed with an opiate and you're trying to wake them up, this is something I've never seen personally, but I'm told by colleagues that when you give them the naloxone, they sort of go from zero to, it like wakes them up. But it also immediately throws them into withdrawal,
Okay.
right? So because you've blocked it off. So it's just something to keep in mind. Now, does everybody who suddenly stops taking their benzo have a seizure? No, but it can happen, and that would be why it would happen. Okay. The other thing people use for sleep is an over-the-counter medication. There's a couple of them. Diphenhydramine is Benadryl, the drug that helps your sneezing. It's a first-generation antihistamine, meaning, what does first-generation mean? A first-generation drug. The first generation of the people in your family that came to this country are the oldest ones, right? So these are these are the first drugs in their class, and these drugs are less, specific, less selective, all that stuff. So diphenhydramine, doxylamine, which is in NyQuil, Dramamine, that's in the one you use for being in the plane. Those are all first-generation antihistamines, and they all make you sleepy because they cross the blood-brain barrier and they bind. What kind of receptor do you think? An histamine receptor, right? They're histamine antagonists, and they make you sleepy. So, because it's so common to be sleepy with these first-generation antihistamines, you can use them as an antihistamine, but you can also use them as a sleeping aid. So, very commonly used as a sleeping aid. Supposedly, they can have a paradoxical reaction in old people or young people. So some, and again, different species. So those people, if they take diphenhydramine, instead of feeling sleepy, they get a little more activated and awake. So again, I don't want to deal with babies or old people. It's too confusing. All right. They can interfere a little bit with REM sleep, but nothing like the barbiturates. Okay? All right, so again, I'm always going to be asking you for the bold-faced drugs. I'm giving you this other information for later in your career. All right, the bold-faced drugs are what I'm looking at. Okay, and a sedative should only be used for 2 to 4 weeks. All right, drugs that are for anxiety. So an anxiolytic is the name of the drug class. It just means drugs that help you with your anxiety. So anxiety, the feeling in your body of anxiety, that's the sympathetic nervous system. So your heart's pounding and you feel all like you want to run out of the room. And then the limbic system, that's the part of your brain that's for like strong emotions, like anxiety and rage and lust, and love, and all all those big, strong emotions. So the drugs are kind of aimed at those. Again, benzodiazepines and barbiturates. I don't have barbiturates listed here. I think lower on the page I mentioned it. Because there's so many other better drugs that people don't use barbiturates. But you could. You could use it for that. Again, I'm only asking you to know both razepam and diazepam. But generally speaking, other benzodiazepines are used. Have any of you guys ever been prescribed Valium for anything? I had a string of 6 months where I got rear-ended like 4 times. I don't know, I haven't been rear-ended, I don't know why. I just wanted to run into the back of my car. And I kept getting like repeated whiplash injuries. And so every time I would go in, they would give me diazepam as a muscle relaxant. Diazepam also works as a muscle relaxant. It's like a great drug. But if you've ever tried diazepam, it is awesome. I mean, you totally see why people get addicted to it. And the reason that it's a pleasurable drug to take is because it has a fairly rapid onset. So you actually kind of feel like the anxiety pouring away from you because it's very fast acting. It doesn't last long, but it's fast acting. Whereas something like alprazolam or clonazepam are longer acting drugs. So if you give those drugs to an anxious person, they won't necessarily feel the anxiety draining away from them quickly. It's just that after a while they'll notice, oh, hey, I don't feel anxious now, because it's longer acting, so you don't have that sudden rush. So the short acting stuff tend to be the things that are more addictive. That's why people want to, what's the one that you smoke? I can't remember. There's one you smoke, is it marijuana where you smoke it and it works faster than putting it in a food? I don't know. Anyway, like, that's the idea why people are trying to put alcohol in their eyeballs and stuff, because they're like, oh, I'll get these sensations fast, and that'll be like much more. Or like opiates. People want to put it in their veins because then they get a sudden onset of action, and that's what gives you that.
Or the bird that the college students are putting it like in a funnel and like up their butt.
Yeah, did I not talk about that? Did I talk about that in this class? Okay, I should mention. Okay, so with alcohol, right? The fastest absorption to your bloodstreams is through either mucous membranes or you drink it and it goes into your stomach, right? First of all, alcohol is absorbed incredibly quickly through your stomach. So you can just drink it, that's fun too. The other thing is, if you put it in your mouth, it's absorbed very quickly through your mucous membranes of your mouth, because that's why there's lots of drugs that you can take sublingually or whatever, because your mouth is so incredibly heavily vascularized because it's such a filthy part of your body. You have your teeth and everything. So lots of blood vessels means that if there's an injury, white blood cells can get there very quickly. So that's a very fast way of getting alcohol into your body. It's just put it in your mouth or swallow it. I've also seen where people put alcohol on their eyeball, because I guess the logic there is that your eyeball is a part of your brain. So if you put it on your eyeball, you're putting it on your brain. The problem with that logic is your sclera has no blood supply. That's why it looks white. There's no blood supply there. So that's like the worst place to put it. You might as well put it on your teeth. I mean, it's just not going to get into your bloodstream. So that doesn't work. I've heard of people putting it on tampons and putting it in their vaginas, and people putting it in their rectum. There's no reason to do that. Your mouth is the best place to put it. That's the most vascular place. I've also seen some people say, well, if you put it in your butt, then you can pull over for driving. Your blood alcohol will be normal. No, because because the blood, it goes into your blood, and the way that they test the blood alcohol is through your breath, because it's excreted through your lungs. So it doesn't matter how it got in your body. It won't have an effect. So if you've until now been putting beer into your rectum, you can stop and you can start putting it in your mouth. That'll be fine. Now I should mention there was another famous study, I think in the 80s or 90s. At a college campus, and what they did was they took two big groups of college students who were all, I guess, legal for whatever state it was. And each one of them, they said, okay, here's a party. And they put a big bowl of punch into the room, and they told the students that it was spiked with alcohol. One was spiked with alcohol, the other one was just punch. And both sides, they had an equal amount of drunkenness in both groups. And people who were, I mean, like you could test their reflexes were off, so they really were drunk. So if people are putting alcohol in their eyeballs or up their butt, and they say, oh, I get way more drunk, that's probably up. I don't drink alcohol, but I find that I always tell people, like, you have to drink to catch up to me, so my normal state is, yeah, so there's lots of things about alcohol, like, yeah, don't put it in your bottom, it just seems like it would be really uncomfortable too, I don't know. Okay, so, all right, so, so benzodiazepines work, barbiturates work, and here's one of these surprise things. So selective serotonin reuptake inhibitors, or SSRIs, were developed for depression because the drugs that were available before, I think Prozac was the first one that came out in the 80s or 90s. Before that, all they had was MAOs and TCAs and lithium and shock therapy. There weren't a lot of really good treatments. Not good, but weren't, all the treatments had side effects or were hard to use or dangerous or whatever. And when the SSRIs came out, it was like a big party. Everybody got Prozac that day or whatever, because all these people who had been walking around with depression had never been treated. And the SSRIs have a much safer profile. They're a lot easier to deal with. And what they noticed was, when they had all these millions of people taking Prozac, was people started reporting, you know, my patients that have depression and anxiety, their anxiety is getting better. And that would be a phase 4, right? That's a phase 4 thing. So they put together some people put together some studies and showed, yeah, SSRIs do work for anxiety. Nobody really knew that. We knew about benzodiazepines and barbiturates, so we thought, well, anxiety, GABA, you know. But it turns out that another neurotransmitter is actually also helpful in anxiety. What neurotransmitter do you think it is from the name of this drug? Serotonin. So if it's a selective serotonin reuptake inhibitor, what's the mechanism of action?
It inhibits the reuptake process.
It selectively inhibits the reuptake of serotonin. So it's an indirect acting drug that increases serotonin all over your body. Okay, so what that told everybody was serotonin has something to do with anxiety. This is great. We're going to now work on more drugs to use to target different types of anxiety. So there's a lot of SSRIs now that are being used for OCD, that are being used for phobias, for PTSD, and for anxiety associated with depression, with really good results. So it's one of those things that it doesn't make sense. It's an antidepressant. Why do you use it for anxiety? The way I remember it is I'd say that SSRIs make you feel content. So no anxiety, no sadness, content. That's how I remember it. Yes?
So it doesn't like help with all anxiety and all depression, just certain types?
Right, because again, it's a huge spectrum of disorders. There's a tremendous amount of genetic variation between patients. You know, drugs that work for one person, there's a chance it won't work for another person. But there's a lot of people that have really benefited from this. Okay. You can use other antidepressants, but you're going to try other things first. I do want to mention 2 other sort of weird things. There's a drug called Buspar, which is used for anxiety. And the nice thing about Buspar is that supposedly it doesn't interact with alcohol. So if you have a patient that's drinking alcohol for their anxiety, you kind of don't want to give them a benzo or barbiturate because you don't want to kill them by accident. But supposedly Buspar doesn't work synergistically with alcohol. The drawback to Buspar is it takes a few weeks to work. Now, here's where I don't like CNS drugs. Heart drugs all make sense to me. CNS drugs make no sense to me because of things like this. Buspar, can you use it for insomnia? It seems like you should be able to, right? It works for anxiety, so it should help you for sleep, right? Buspar keeps people awake. Why? Brain is weird. There's lots of connections. We don't know. So, in terms of using a drug for somebody who's drinking alcohol, for sleep you can use melatonin, no problem. Totally doesn't have anything to do with GABA or chloride or anything. For anxiety, you can try Buspar. Right? So does that make sense? It doesn't make sense to me, but that's how it is. And then lastly, propranolol. I told you guys propranolol would be on every single test because it has so many indications. Already, what indication have we learned so far? Propranolol, Volol, it's a Volol drug. Yeah, beta blocker, so it's used for heart rate, blood pressure, because it reduces heart rate, so it reduces blood pressure. The propranolol also can be used to reduce the sensation of anxiety. So propranolol, if you take propranolol for anxiety, it's most commonly used for stage fright, or when you have to give a talk in front of thousands of people. It's quite good for that. I've also known a bunch of surgeons who took propranolol for tremors. Their hands would shake when they operated. And that's a central weird brain thing. Central means brain, peripheral means everything else but your brain is spinal cord. So if you have asthma and you take a beta-2 agonist, right, like, what kind of drug? Albuterol. One of the side effects can be tremor, handshake, okay? And that's because some of the albuterol gets to your brain and for whatever reason makes your hands shake. Propranolol, which has got that beta-2 blocking action, if you take that and it gets into your brain, it makes your hands stop shaking, right? So there's another indication for propranolol, and what's the contraindication we learned so far? People with asthma because of the beta-2 blocking. Do you have a question?
Can you ever use just one drug to like help someone, or do they all?
No, you can totally use one drug. It might not work. You might have to give them another drug for their side effects. But yeah, no, there's lots of situations where you can use one drug. Just as you get older, you get more problems. And you get old. All right, so again, I'm not breaking it down by anxiety, just anxiety. These are the drugs you use, okay? Later on, you'll figure out which drugs are best for what kind of anxiety. Okay, same thing with seizures, okay? So seizure is too much activity in your brain, and having your brain firing and releasing all of its neurotransmitters is not good for it in the long run, and so you want to stop a seizure. There's all different kinds of seizures. There's localized seizures in your brain. If you have a seizure that affects the motor cortex, what will you see when you look at a person having a seizure? Yeah, you'll see that tonic-clonic, right? So the muscle contracts and is firmed up. My dad has temporal lobe epilepsy, so I've seen him flop around on the floor. Have any of you guys ever seen somebody have a seizure? I'm sure there's a few people. Isn't it terrifying to see? It's terrifying. It doesn't look like in the movies where the actress has all her hair and makeup done, and she's like, "Yep, that's not what it looks like." They turn pale, their eyes roll up, they have this horrible expression, and it's awful. There's a word for a seizure that lasts very long called status epilepticus. That means a seizure that's lasting more than like 5 minutes. If you're watching someone have a seizure, 5 minutes is like eternity. Watching someone have a seizure for 10 seconds is like eternity. So if any of you have ever seen someone do that, you know it's really scary. So you need to stop a seizure that's lasting long. You have to. And the first line drug for that is our buddies, lorazepam and diazepam, all right? So those are the first line treatment for that. And those are the two drugs. I'm not just teaching you some random benzos. Those two are the ones to learn. They're short acting, so they should work pretty quick. Those are the ones you need in an emergency. So if there's drugs that you need to know immediately, you can't spend time Googling and looking it up, those are the ones I'm going to also ask you to learn. So those are the two to learn. And I already talked about diazepam and alcohol withdrawal. So, what else do I want to make sure that I tell you? Oh, this is just terminology. An anticonvulsant is a drug that you use to stop a seizure in progress. This person's seizing in front of you, you give them a drug to stop the seizure. An antiepileptic is a drug that a patient would take, every day to keep from having their seizures. Okay. Again, benzodiazepines, we already talked about that. Barbiturates, like phenobarbital, you can use that. If the lorazepam diazepam doesn't work to stop the seizure, you can try phenobarbital, or dilantin is another one. Phenobarbital is also used a lot because I think I mentioned already, the side effect of that hangover from the REM sleep problem wears off after a couple weeks for most patients, so they can use that. I'm adding in boldface the drug Keppra because I was asking the nursing faculty about drugs to put in, and they're like, you gotta put in the Keppra. So Keppra is an anti-seizure drug. So just want to make sure that you can identify that. These other drugs are all commonly used drugs, but again, I'm trying to like minimize the total number of drugs for you at this point, because it's the drug class, this idea of inhibiting a seizure is what I'm really after. Benzodiazepines, barbiturates, and all these three old-timey drugs all cause very high percentage of fetal malformation. So if you are a woman with long-term seizure disorder, you're really in a bind in terms of getting pregnant because you're really running a risk of having birth defects. Phenytoin or Dilantin is an old-timey drug. It's got a couple of things you need to know about it. One of which is it causes something called gingival hyperplasia. So let's find a really juicy one here. All right, so this is gingival hyperplasia. It just means giant gums, right? And this, what you're seeing here is not swollen gums. It's not infected gums. It's all gums. It's gums all the way down. It's just gums. And so often those, when the gums sort of overgrow like that, you actually have to have them surgically removed because it's not like it's just swollen. I mean, that's all gum tissue. You have to, if a patient develops this, it actually can be life-threatening in that you have a tooth and then you have the gum growing over it. And then there's a pocket between the gums and the tooth. So that's like a setup for tooth decay. And you might say, well, tooth decay, that's pretty bad. But it is bad because I've seen one patient in my year of internship of a person who had a tooth abscess that got into their brain. Because the tooth abscess is up here, it's right near your sinuses, and then it goes into your brain. So people who have this gingival hyperplasia, which is a fancy way of saying big gums, you have to make sure that they learn how to take care of their teeth if that happens. You can use things like a water pick and stuff to make sure you get that cleared out. But yeah, you can't miss it. I think that's pretty, yeah.
So is this like an immediate effect of the drug, or is this after years of use?
You know what, I don't know. I remember my dad, they originally offered him this phenytoin. He's like, I don't want to have giant gums because he's like me, so when he smiles, he's like mostly gums. So I'm not sure how fast it comes on.
So, but presumably somebody would know that it's happening, they can just continue.
Right. Well, if they discontinue it and they have a seizure, anyway, it's right. So you could discontinue it and try something else. Right. If you're using phenytoin to stop a seizure in progress because the other drugs didn't work, you have to inject it slowly because you don't want to cause an arrhythmia. I don't know why I'm asking that question. You want to inject it slowly so you don't cause an arrhythmia. And that should make sense. Are you guys doing heart yet? Those of you that are taking A&P too? Just started it. Okay. So like this week or next week, you'll learn about the SA node and the transmission of the electrical signal throughout the heart, right? And in the heart muscle, there's something called the cardiac action potential, which is just like a normal action potential, except calcium's in it too. So the action potential you already learned was sodium and potassium. The cardiac action potential is sodium, potassium, and calcium, just so that the signal doesn't go as fast. So it should make sense that a drug that works to hyperpolarize or depolarize brain cells probably can hyperpolarize or depolarize heart cells. Does that make sense? Like a sodium channel in your brain and a sodium channel in your heart are both sodium channels. So if you inject it, you have to inject it slowly or put it in the, you can't just like put it in the vein and like push it in as fast as you can. Because if you do that, you have like this bolus of the drug and it goes right heart, lungs, left heart, out, right? And then so you have this bolus of the drug and it hits the heart and you can cause an arrhythmia. So that's just a precaution for anybody who might be giving that drug to stop a seizure. The other thing is it causes a condition called Stevens-Johnson syndrome, which I think I mentioned in the first handout. Stevens-Johnson to me is the worst possible side effect. What happens is the patient will notice that they're getting blisters on their body, either on their body, sometimes it starts in the mouth, and the blisters keep getting bigger, and then pretty soon all the blisters merge, and then your skin falls off. So, and that's like having a burn over your body, right? So it is quite lethal. It turns out Stevens-Johnson syndrome seems to mostly be caused by certain genes. So it doesn't happen to everybody, but the few people it does happen to, it's because it seems to be it's always a genetic reason. You can get Stevens-Johnson also with carbamazepine, which, they found the gene for that. So hopefully 10 or 20 years from now, we'll be able to screen people so that they don't have these horrible idiosyncratic reactions. So that's phenytoin. There's carbamazepine or Tegretol. That's another anti-seizure drug. The anti-seizure drug that one is also sometimes used for mania. Totally different condition, but for some reason it works, so people use it. And valproic acid, which is Depakote or Depakine, that one works. All right, I'm going to have to stop here, I think, in terms of the quiz, but I'm probably going to ask you to read through some of this on your own. Just want to make sure there's enough. Oh, can I show you one more thing, which is just, and because I'll probably forget next time. One of the anesthetics is called ketamine. It's evidently used on the street as Special K or Molly, it's called. It's used as a street drug. It's been in the news a lot lately because people are claiming that it might help get somebody out of a suicidal depression faster than normal antidepressant drugs. But I just want to show you something called the ketamine dissociative anesthetic state. Okay, so I found on the internet, I found this. So this is a little boy who, I think they show him here. He's a little boy, and he hurt his lip, so you can see he has a hurt lip. So they give him the ketamine. Let's see. Let me just make sure there's sound is on here. Okay, there we go. All right. And this is also why you send the parents out of the room often when you do a procedure with ketamine in a child, because it looks really scary. So here you go. So here's this kid. So he's upset because he hurt his lips. It happens pretty quickly.
Put your camera on it, boy. A big boy, remember? Take a picture.
There we go.
And that's it. So now they'll show some of his face. It looks very scary and weird. So he's got his eyes open, not moving.
Perfect.
I think that looks scary. And people abuse this drug on the street, and often what happens is they sort of get near this state and then like wander into the path of a car or a truck or something. But that's how you would use it as an anesthetic in a child.
Yeah.
All right. Anyway, I'll link that to you. I'm sure it was a happy ending there.